Hello and welcome to 5-Minute Nephrology. My name is Dr. Nephron, because anything saltier would be bad for your health. Today we're going to learn about IgA nephropathy, all in about 5 minutes, but don't hold me to it. The definition of IgA nephropathy is when one has hematuria plus or minus proteinuria in the proper context. We will discuss the clinical features shortly. Or recurrent hematuria plus or minus proteinuria that prompts a biopsy which demonstrates IgA deposition in the mesangium on immunofluorescence, where it's either the brightest or very bright on immunofluorescence. While one can make a clinical diagnosis based on signs and symptoms, the only way we can make the definitive diagnosis is by doing the biopsy. The biopsy is important as the classification uses the MESC scoring, which evaluates the location and severity of the inflammation, which is not really necessary for you to know, but it does help determine the risk of progression in adults. However, pediatric histologic findings do differ from adults, so the jury is still out in the pediatric context. The epidemiology of IgA nephropathy is that it is the most common primary glomerulonephritis worldwide. The typical pediatric presentation is around 10 to 12 years old, although it can appear earlier and has a much higher prevalence in East Asia and Europe. In adults, 20 to 40% progress to kidney failure within 10 to 20 years. However, while pediatric data is mixed, around 10 to 20% develop significant CKD and even ESRD over 10 to 20 years. The pathogenesis of IgA nephropathy is known as the 4-hit model that has been developed over time. What's interesting about the 4-hit model is part of the reason it was developed is the necessity of it, because many of the steps here, for example, production of the galactose-deficient IgA1, have other people who are deficient in IgA1 and do not develop IgA nephropathy. And that goes for many of these steps. For our purposes, production of galactose-deficient IgA1 is formed. The body then forms antibodies against the abnormal IgA1, leading to circulating immune complexes that then form and are deposited in the mesangium, which trigger inflammation and fibrosis. Interestingly, IgA nephropathy does have a strong genetic component. Many of the genes are related to mucosal immunity, which makes sense as mucosal surfaces is where IgA nephropathy is active there. While there are genetic factors, most cases are sporadic, meaning a patient can have the disease even when there's no family history of IgA nephropathy. What are clinical features of IgA nephropathy, you ask? Well, synpharyngitic, typically gross hematuria, which means that the hematuria occurs at the exact same time as the illness, whether it is a URI or sore throat or whatever, which recurs with subsequent URIs, but in between episodes there's oftentimes microscopic hematuria. The proteinuria is of varying severity. Sometimes it's subnephrotic, sometimes it's minimal, and proteinuria itself gives us an insight into how significant the disease burden is. What is rare is nephrotic range proteinuria and rapidly progressive glomerulonephritis, meaning RPGN. Lab findings of IgA nephropathy has normal complement levels, hematuria with dysmorphic RBCs and RBC casts, which indicates glomerular bleeding, as opposed to the lower urinary tract, and while the bleeding can be significant and can fill the toilet with red color, specifically the hematuria of IgA nephropathy or typically any nephritis of any sort does not in itself cause anemia. Proteinuria, as we mentioned before, is the strongest predictor of disease progression, but because of orthostatic proteinuria, etc., we prefer a first morning urine protein-creatinine ratio if possible. Typically the creatinine is usually normal, but may be elevated, and as mentioned earlier, some patients do progress. The most common of the differential diagnoses include IgA vasculitis, PIGN or PSGN, lupus nephritis, and C3 glomerulopathy, which is a part of the NPGN family, as well as Alport syndrome. Clinically, the distinguishing features of IgA vasculitis, what was formerly known as HSP, while it does have a very similar IgA deposition on biopsy, but it does come with other features, such as the purpuric rash, the abdominal pain, and the arthritis. Remember, serum IgA is not a useful test. PIGN, the nephritis, the hematuria, hypertension, AKI, typically occurs after the infection, anywhere between 2 and 4 or 3 and 6 weeks afterwards, depending on the site of the infection, whether throat or skin, respectively. It also has a low C3, has an elevated ASO and anti-DNase B in PSGN. Lupus nephritis usually comes with other features, such as a positive ANA, anti-double-stranded ANA, and often has systemic features as well as both low C3 and low C4. C3 glomerulopathy, which is considered if you thought you had PSGN that doesn't resolve, and as I mentioned is part of the NPGN family, has persistently low C3 and has dominant C3 on immunofluorescence when seen on biopsy. Alport syndrome, which does have the macroscopic hematuria and can be exacerbated during infections, but there's oftentimes a family history. It also comes with hearing loss, as well as vision loss, depending on the inheritance and the mutation. So we have a sample case. A 12-year-old boy presents with Coca-Cola urine during an upper respiratory infection. He had 2 similar episodes during URIs, when he's also had Coca-Cola urine. Blood pressure is mildly elevated. The UA shows hematuria, RBC casts, a urine protein creatinine ratio of 0.8, which is elevated but still subnephrotic, and of course, there is gross hematuria. Complement levels are normal, and his creatinine is slightly elevated, and his hemoglobin is normal. On the kidney biopsy, he has some mesangial IgE deposition, and therefore we have a diagnosis of IgA nephropathy. On your boards, they would typically give you the first half of the case, where the Coca-Cola urine occurs during the upper respiratory infection, and overall he's doing okay, but they might give you a case where there is affected kidney function, but most importantly, to make the diagnosis, the complement is normal. What are the treatments in IgA nephropathy? Well, in pediatrics, our treatments currently are somewhat limited. We start with running ACE blockade to decrease the proteinuria. We also control the blood pressure. If there's persistent proteinuria above a certain level, we'll oftentimes start steroids. There are emergent therapies, especially in the adult world, as it relates to IgA, especially SGLT2s, those are the flozins, and medications such as complement targeting agents. What you're seeing here on the right are some of the targeted agents in IgA nephropathy. Some of them are a bit more upstream from ACE inhibitors. And in this case, we can target HIT1 and 2 with APRIL and BAFF inhibitors, which reduce production of the galactose-deficient IgA1. There's also other medications that reduce inflammation potential in the midstream and then downstream, like we talked about, the ACE inhibitors, as well as a couple of other factors inhibitors, which may help decrease mesangial damage. But again, don't forget that the serum complements are normal. What are the key takeaways of IgA nephropathy? You need a biopsy to actually make the diagnosis. Children present with synpharyngitic hematuria. Complement levels are normal, and proteinuria is the strongest predictor of progression. So these kids definitely need nephrology follow-up. In this last slide, we have some of the references that are applicable if you'd like to take a deeper dive on the topic, because who wouldn't? That's your 5-minute nephrology on IgA with Dr. Nephron. Until next time, you're in good hands with renalforresidents.com.